Assalamu alaikum. My name is Kiran Amir and I am the Director Operations at PARSA ECHO Pakistan Super Hub. I would like to welcome you all to our 5th session in ECHO series on inflammatory bowel disease. It's in collaboration with South Asian IBD Alliance, SAIA, a charitable organization in the United States with a global presence in South Asia, India, Pakistan, and others. A special thanks to Genix Pharma for the unrestricted educational grant. Today's session is titled IBD Extraintestinal Manifestation. Our expert for tonight's session is Dr. Tauseef Ali, medical executive based in US. Before I move forward, we have to go through some standard announcements. We are part of a global movement called Project ECHO based in USA with an objective to disseminate knowledge and best practices. We do protect patient privacy, so none of the information used in this session will identify any individual or patient. For maintaining discipline, you all are muted, but we do encourage participation, so you can unmute yourself for question or use the raised hand option or chat box. By participating, you have given the consent for recording, and the recorded session will be available on our YouTube channel. Link will be shared in the chat box. For CME credits, please contact Uzair or our coordinator. His number is mentioned and his email is mentioned also on the banner. CME credits are affiliated with Jinnah Sindh Medical University. Uzair will share the Google form at the end of the session, which will be active for 12 hours. You are requested to fill it as soon as possible to avail the opportunity of CMEs. For the convenience of spokes, the session is bilingual. Please speak in Urdu or English, whatever language you are comfortable in. If you're interested in PARSA ECHO's publication, please fill the form shared in the chat box. I will now hand over to Dr. Jalpa Devi, our co-moderator for tonight's session. She will introduce Saya and Dr. Tauseef Ali. Dr. Jalpa?
Yes, thank you, Ms. Kiran. I'm going to share my screen. So, can you see my screen now?
Yes, we can.
Okay, so this is South Asian IBD Alliance, and it's a first patient clinician-led non-profit organization in the IBD space, which is charitable organization. With the dramatically increasing numbers of IBD in South Asia, SAIA has formed to create resources, research, and education for IBD patients and healthcare providers of South Asian origin to minimize disparities, dispel stigma, promote early diagnosis, and improve access to treatment. So they have 3 component structures and goals, which are patient outreach and advocacy, professional development, and research. And that's how Professional Development Committee has partnered with PARSA Trust Project ECHO to educate general practitioners and gastroenterologists thoroughly about IBD, its pathogenesis, epidemiology, and how to provide the best care and treatment options to patients in a resource-limiting settings in South Asia. And they have the resources on their website you can check. And also there are social media that are active on Facebook, Instagram, Twitter, LinkedIn with this. And also there's a support group for IBD patients, caregivers who can join this group, which is run by IBDSs. And there's an email ID for executive council if you run any idea want to tell them. And there are recent updates which I would like to share with them, with you all, that South Asian IBD Alliance has just awarded by the Global Health Funding for important research that developing artificial intelligence models to distinguish GITB from Crohn's. And last time I told about the innovation challenge, and they have won this innovation challenge by the Tina Osami, and this is with the it's a unmet needs in the inflammatory bowel disease and for Crohn's and Colitis Congress. And also if any resident and fellow would like to join the IBD club, they are more welcome to join. And also there are articles, journal clubs that are shared on the IBD club YouTube channel. And today's topic is IBD Extraintestinal Manifestations by Dr. Tauseef Ali. He's a consultant gastroenterologist and IBD specialist, and he's a medical executive director for SSM Health Digestive Health Institute and SSM Health Crohn's and Colitis Center. He's a clinical assistant professor at University of Oklahoma and Oklahoma State University, and he has written the book on Crohn's and Colitis for Dummies, and he is a well-known chair of the Public Relations Committee and governor of the Oklahoma chapter of the American College of Gastroenterology, and member of the board of directors of the American College of Gastroenterology. And he is a member of AGA and Crohn's and Colitis Foundation and South Asian IBD Alliance, and serves on various committees. And he's recognized internationally for his clinical work in Crohn's and colitis. You can find him on social media with a Twitter handle that's IBD Tweets. And also he's going to present lectures in upcoming conference, Pakistan Society of Gastroenterology in 2023. And hand over to Dr. Tauseef.
Jalpa, if you can stop share, please.
Here, can you guys hear me?
Yes, we can.
Okay. Well, hello, everyone. I know it's late night, so I'm not gonna take much of your time. Hopefully in 20 minutes, I will finish my presentation. If not, someone can just give me a signal that it's 20 minutes so I can wrap it up. So without further delay, I'm gonna go ahead and start. I'm just making some adjustment to my screen so I can take these things away. So extraintestinal manifestations in inflammatory bowel disease, it's a very interesting topic because it encompasses the entire medicine. So if you like medicine, you will enjoy this talk. And that's my passion when I take care of IBD patients. It's this holistic approach when you take care of IBD patients and when they present with all these different types of extraintestinal manifestations. I'm having a hard time advancing my slides, so hopefully they are moving now. So as we all know that IBD is a systemic inflammatory condition. It frequently involves organs outside GI tract, and extraintestinal manifestations in IBD can occur prior to the diagnosis of IBD. So these patients can present with extraintestinal manifestations even before the diagnosis of IBD. They can run the independent course. So their IBD can be in remission, but they may have extraintestinal manifestation that may be causing problem. These extraintestinal manifestations are common in Crohn's disease compared to ulcerative colitis. They can be life-threatening. For example, primary sclerosing cholangitis and venous thromboembolism that can increase the risk of mortality also. And it does affect the quality of life. And we will talk about this in our next slides. So one thing to appreciate the difference, extraintestinal manifestations and extraintestinal complications. So complications are the direct or indirect sequela of intestinal inflammation. So inflammation is happening in the gut, and because of that inflammation in the gut, you are developing some complication. That's called extraintestinal complication. Extraintestinal manifestations are the inflammatory processes that are happening outside the gut. So actual inflammation happening outside the gut. Extraintestinal manifestations in IBD can involve different organs. As you can see here, patients can have arthritis, they can have inflammation in their tendons, it can involve skin, you can have Pyoderma gangrenosum, Erythema nodosum, sweet syndrome, aphthous stomatitis. We will talk about these in greater detail in my next slides. Hepatobiliary tract manifestations can happen. The most common one that you may have heard is primary sclerosing cholangitis. And then you have eye complications, for example, episcleritis, uveitis, or even iritis that can happen. Some of the complications are rare, but in this very dense graph or image, what you are seeing that Autoimmune hepatitis can happen in IBD patients, although it's rare. Similarly, you can have orofacial granulomatosis, which is the inflammation that happened in your oral cavity, and I'll share some images with you also. Similarly, you can have pneumonitis. You can also have portal vein thrombosis. These are all different types of extraintestinal manifestations. The overall prevalence is about 6 to 47%. Typically, when I talk to the patient, I round it up, और मैं उनको ये बताता हूँ कि ये 10 से 50% chances हैं कि आपको extraintestinal manifestation भी हो सकती हैं. और जरूरी नहीं है कि सिर्फ एक ही हो. You can have more than one. It can happen up to 5 extraintestinal manifestations in a given patient. So you can have more than one. And that can happen in about 1/4 of the patient, or 25% of the times that your EIM or extraintestinal manifestation affected patients can have several EIMs. EIMs typically happen in early onset IBD and younger patients. So look for these extraintestinal manifestations, screen for these in your younger patients. Most common is arthritis. So always ask questions about जोड़ों के दर्द तो नहीं हो रहा, muscles में pain तो नहीं हो रहा. Also common is aphthous stomatitis. So make sure you do a good examination of oral cavity, buccal mucosa. Similarly, eye problems can happen, uveitis can happen, and then erythema nodosum. So watch for these skin nodules, and we'll talk about these, how they look like in our subsequent slides. Remember that I explained that EIMs can happen even before the diagnosis of IBD. About 25% of these patients have EIMs before they were actually diagnosed with IBD, and that can happen from anywhere from 0 to 25 months. So it can 2 साल पहले भी इनको joint pain start हो सकती हैं, and you have to make sure that you ask them about gut problems, diarrhea, abdominal pain, and many times we get referral from rheumatologist, and they have patients with arthritis, and now they're starting complaining of some abdominal symptoms, or they sometimes have a very high suspicion of IBD, and then they send these patients to get colonoscopies or CAT scans to make sure that they do not have IBD. Patients who have PSC, many times our liver specialists who diagnose patients with PSC send those patients for colonoscopy to make sure that these patients don't have ulcerative colitis or Crohn's disease. And then extraintestinal manifestations can also happen later after the diagnosis in these cases. Why do these extraintestinal manifestations happen? What is the reason that these patients are having inflammation outside the gut? There are 2 main reasons, or 2 main buckets. One is that it is the extension of the immune responses that are happening in the intestines. Or the second bucket is that it is an independent inflammatory event. It has nothing to do with the inflammation in the gut. It is a shift in the inflammatory tone, and now that there are other organ systems that are being involved because of this. There are some genetic risk factors for extraintestinal manifestation also. As you can see, again, a very dense slide, but if you look at this slide, I don't know if you can see my mouse moving here. You can see that the down one, the bottom one, ankylosing spondylitis, the gene is interleukin 23. Similarly, you can see that in uveitis, the very infamous gene NOD2-CART15, which was the gene that was involved in the pathogenesis of Crohn's disease and discovered in 2001, that gene is also involved in causing patients to have uveitis. So very interesting. So now let's go into the individual individual extraintestinal manifestations. Musculoskeletal, आपके joints की, muscles की problems can happen in about 50% of the patients. So about 46-50% of the patients, IBD patients, can have extraintestinal manifestations involving your joints and muscles. I mentioned earlier also that typically these happens in a young age, and as you can see here also that the prevalence of arthritis decreases as the patients increase in their age. So typically in the age group of 20 to 30, these patients have more musculoskeletal EIMs compared to the patients in their 50s and 60s. Different types can happen. You can have arthralgias without arthritis. You can just have joint pains, but there is no inflammation. That can happen in about 5 to 10% of the patients. Axial arthropathy, ankylosing spondylitis can happen. Isolated sacroiliitis can happen. Sometimes they can have just inflammatory back pain. और बहुत सारे मरीज कहते हैं कि उनकी पीछे कमर में दर्द हो रहा है या हिप जॉइंट में दर्द हो रहा है, उनसे वॉक नहीं किया जाता, उनसे खड़ा नहीं हुआ जाता. These are because they may be having arthritis. So make sure that you ask these questions and screen these questions to your IBD patients. Dactylitis can happen, which is the swelling of your entire finger, but enthesitis can happen, which is the inflammation of the tendons and ligaments. Let's talk about skin manifestations. That can also happen in about 5 to 15% of the patients. The most common ones and the most commonly tested in exam also is erythema nodosum and Pyoderma gangrenosum. These are the two common ones that happens, the skin manifestations. The other ones are hidradenitis suppurativa. We see patients with that, and typically we treat them with anti-TNF therapy that actually treats hidradenitis suppurativa as well as your Crohn's and colitis also. Metastatic Crohn's disease, it is the Crohn's disease of the skin, that can also happen. Psoriasis can happen, skin cancers can happen. So when you are examining your patients with IBD, make sure that you are doing a good skin exam. Look for lumps and bumps. Those lumps and bumps could be your erythema nodosum. Look for any pustules or skin color changes, a little patch, that could be a psoriasis patch. And then also obviously look for any skin cancers. Erythema nodosum, as the name itself give away what are these lesions. Erythema nodosum, erythema mean redness, nodosum mean nodule. So these are your red nodules. These are very tender red nodules that happens typically on your legs, the lower extremities, on the tibial area. You will see these little nodules that happens. It can happen in your thighs or also in your forearms. You can see those. Most commonly happens in Crohn's disease. And if you look on the side, you will see that mostly they happen in inactive disease in Crohn's disease. And interestingly, in ulcerative colitis, it happens mostly in active disease. So if you have active colitis, you will see more erythema nodosum. In Crohn's disease, it's the other way around. In inactive Crohn's disease, you will see more erythema nodosum. You can also have, along with these nodules, joint pains. So peripheral arthritis is very common. So if you have seen skin nodules, make sure you ask about arthritis also, or vice versa. If you're seeing arthritis, make sure you do their skin exam and make sure that they're not having erythema nodosum. Typically, when you treat the inflammation in the gut, you actually treat the erythema nodosum also. If it doesn't work, then sometimes we have to give them a steroid burst, typically starting with 40 to 60 milligram of prednisone and then slow taper, or sometimes you have to use biologic drugs such as anti-TNF therapies. Pyoderma gangrenosum is another skin manifestation. Again, the word itself explains what's happening. Just like in erythema nodosum, you have erythema, redness, and nodosum nodules. Here in Pyoderma gangrenosum, pyo, pus, derma, skin, gangrenosum, gangrene. So it's like very pus forming skin gangrene that you see. So these are your erythematous pustules or nodules that are rapidly developing into deep ulcer. So they will come with a very small ulcer, but very rapidly in days or weeks, you will see that it has now grown up and the ulcer is becoming bigger and bigger. And it has very purulent material, pus coming out of those ulcers. And 50% of the patients who present with Pyoderma gangrenosum have underlying IBD. So we get a lot of referrals from dermatologists. When they diagnose a patient with Pyoderma gangrenosum, once again, they send these patients to gastroenterologists so that they can get their colonoscopy or endoscopy or get screened for IBD, because they know that when you see a pyoderma gangrenosum, there's a 50% chance that these patients may have IBD also. Patients with severe disease, colonic involvement, are most likely to develop pyoderma gangrenosum. Sometimes when patients have ulcerative colitis or Crohn's disease, they got colectomy and now they have ostomy, like ileostomy or colostomy, they start developing ulcer around their stoma, around their ostomy side, and that ulcers start getting bigger and bigger and bigger. And that can also be because of pyoderma gangrenosum. So it's called peristomal pyoderma gangrenosum. Typically, the diagnosis is made clinically. You avoid skin biopsies because once you start biopsying or irritating it, it actually becomes worse and worse. The treatment is usually oral steroids, just like erythema nodosum, but sometimes they do not respond to steroids, and then you have to go to other medications, immunosuppressive drugs, cyclosporin, tacrolimus, anti-TNFs, and sometimes now we use ustekinumab, which is the interleukin-23 blocker. The other interesting one is sweet syndrome. These are the patients who will present. इनको बुखार हो रहा होगा, इनकी skin के ऊपर ये small nodules आपको नजर आ रहे होंगे. So this is called sweet syndrome. It's also called acute febrile neutrophilic dermatosis. So it is an acute condition. You get fevers with it. You see a lot of neutrophils on the, जब आप इसका complete blood count कराएंगे, आपको lots of neutrophils नजर आएंगे, and then dermatosis. And you can see the skin lesions also, which are again very tender and papulosquamous nodules or xanthemas, जिस तरह आपको इस तस्वीर में नजर आ रहे हैं. Typically occur in female patients. And once again, you can also have arthritis with it, eye problem also. It does peril the disease activity. And very rarely it can also happen in patients who are taking azathioprine, Imuran. So these are your immune modulators that you use. So just be aware of this. So if your patient is on azathioprine and now complaining कि मुझे बुखार हो रहा है और मेरी skin के ऊपर ये rash बन रहा है, so just make sure that it is not sweet syndrome. And the treatment is, again, you can use topical steroids अगर आपको rash या skin lesions नजर आ रही हैं, or you can also use corticosteroids. The dose is usually 40 to 60 milligram of prednisone. अगर आप hydrocortisone use कर रहे हैं, तो just make sure you do the conversion from prednisone to hydrocortisone. Immune modulators, different other types of immune modulators. And the thing is कि अगर इनको Crohn's disease या ulcerative colitis है, तो make sure कि you are treating their disease also aggressively. Metastatic Crohn's disease can also happen. उसमें आपको skin lesions नजर आएंगी, and when you biopsy them, you can see granulomas. That's how you make a diagnosis of skin Crohn's disease. Genital or vulvovaginal lesions are very disabling. They're very difficult to treat. Again, you use topical, systemic steroids, immune modulators, combination therapies, anti-TNF therapies to help these patients get better from these lesions. Last few slides, oral manifestations can also happen. Crohn's disease में ज़्यादा होती हैं, 20 to 50% of patients with Crohn's disease, and it's less common in ulcerative colitis, about 8%. And again, oral lesions can also happen before the actual diagnosis of Crohn's disease and ulcerative colitis. Oral lesions क्यों होती हैं? There are many reasons. Most common are 4 reasons. One, कि आपके जो salivary glands हैं, they are also producing a lot of inflammatory proteins. So that is causing damage in your oral cavity. Similarly, you can have dysbiosis in your oral cavity. Malnutrition is also common in Crohn's disease and ulcerative colitis. Typically in Crohn's disease, malnutrition is common, and that's why you see a lot of oral lesions because of malnutrition. And then sometimes it could be medication induced. Some of the medications can cause that. It's an extensive list of different oral manifestations. As you can see here, कि Crohn's disease में ज़्यादा है, ulcerative colitis में कम है. एक manifestation है जो सिर्फ ulcerative colitis में है, pyostomatitis vegitans. बाकी जो है सारी वो मोस्टली क्रोन्स डिजीज में है, जिस तरह आप यहाँ पे देख रहे हैं. Pyostomatitis vegetans, it's actually, the picture is all the way down. You can see the lesions, it's like white spots, दांतों के ऊपर बकल म्यूकोजा में नजर आ रहे हैं. और उसके बिल्कुल ऊपर आप देख रहे हैं कॉबल स्टोनिंग हो रही है, oral mucosa. It could be because of vitamins deficiency and Crohn's disease also. Angular cheilitis आपको right side पे नजर आ रहा है, जहां पे दो lips की junctions पे आपको यहाँ पे erosions और inflammation मिल रही है. Aphthous ulcers, जो लेफ्ट साइड पे पिक्चर में आपको स्मॉल अल्सर्स और इरोजन्स नजर आ रही हैं. दिस इज वेरी कॉमन. Crohn's disease में यू ऑलवेज आस्क कि आपके मुंह में छाले तो नहीं बन रहे, दाने तो नहीं बन रहे, अल्सर्स तो नहीं है, एंड दैट कुड बी बिकॉज ऑफ IBD Crohn's disease also. Ocular manifestations that can happen. The key thing is to recognize it. अगर patient कह रहा है कि उसकी नजर पे इफेक्ट पड़ रहा है और उसकी आंखें लाल हो रही हैं, तो just make sure that you screen them for it. It can be episcleritis, it could be scleritis. The dangerous is the uveitis. तो बाज़ औक़ात it is difficult to recognize कि ये uveitis है कि नहीं है, तो हम फिर उनको ophthalmologist के पास भेजते हैं ताकि they can have more detailed exam of their eye to make sure कि उनको कोई life threatening ocular manifestations तो नहीं है. Uveitis जो है, as I was telling you, it is the middle layer of the eye, and in contrast to episcleritis and scleritis, it is less associated with intestinal inflammation. ये अपना ही एक independent course run करती है, और बाज़ औक़ात ophthalmologist जब uveitis diagnose करते हैं and the patient is also complaining of diarrhea, abdominal pain, they actually send those patients to us to make sure that they are not having IBD or Crohn's disease and ulcerative colitis. Similarly, when we recognize that there is an eye problem, we make sure that it is not uveitis as compared to episcleritis or scleritis. Hepatobiliary manifestations, it's long list. We all aware that PSC, primary sclerosing cholangitis, can happen. IBD patients may, in about 60 to 80% of patients with PSC, they have IBD. Typically, it happens in males, happens in patients who have pancolitis, and also patients who have appendectomy in the past. रूटीन लैब्स जब हम करवाते हैं उसमें अगर आपको एल्कलाइन फॉस्फेटेज बढ़ा हुआ नजर आ रहा है या GGT बढ़ा हुआ नजर आ रहा है, तो यू एक्चुअली गेट अ लिटिल बिट ऑफ रेड फ्लैग कि ये लिवर का मसला तो नहीं हो रहा. अगर पेशेंट को IBD है, स्पेशली अल्सरेटिव कोलाइटिस है, तो मेक श्योर कि आप उसका फिर अल्ट्रासाउंड करा लें या उसकी आप सीरियल लैब्स करा के देख लें कि परसिस्टेंटली एलिवेट तो नहीं हो रहा, क्योंकि देन यू हैव टू थिंक अबाउट PSC ताकि आप उसकी फिर PSC को रिकग्नाइज करके यू ट्रीट अकॉर्डिंगली. Sometimes you see strictures, वो MRI पे आपको या CAT scan पे strictures नजर आएंगे. If the strictures are symptomatic, sometimes these strictures can cause cholangitis because of obstruction. So then it becomes a little bit challenging to manage these patients. PSC prolong अगर कर जाए, तो complications can happen, such as liver cirrhosis, cholangiocarcinoma can happen in these patients. So make sure अगर आपके patient के liver enzymes बढ़े हुए हैं, आपने PSC diagnose कर लिया है, and they are running benign course, and all of a sudden they are coming, और आप कह रहे हैं कि उनका वजन एकदम कम होना शुरू हो गया, उनको रात को पसीने आ रहे हैं, तो make sure you have a very high suspicion कि इनको कहीं cholangiocarcinoma तो नहीं हो रहा, तो then you may need to do a CT scan or MRI or ultrasound to make sure कि कोई mass तो नहीं है वहाँ पे, so that we can rule that out. Lastly, vascular manifestations. Sometimes we forget about vascular complications. Remember, in Crohn's disease, the inflammation, or in ulcerative colitis, the inflammation can also cause blood clots. Typically, it's the venous can happen, like DVTs, deep venous thrombosis, leg swellings ho jati hain, and then we get them an ultrasound and we see कि उनको thrombosis हो गया है. तो अगर कोई पेशेंट IBD का लेग स्वेलिंग्स के साथ आ रहा है, स्पेशली अगर टांग में दर्द के साथ, स्वेलिंग के साथ दर्द भी है, तो मेक श्योर कि आप DVT को रूल आउट करें और उसको स्क्रीन करें. लेकिन आर्टेरियल थ्रोम्बोसिस भी होता है. देयर आर पेशेंट्स हु एक्चुअली गेट heart attacks, patients can get strokes, and that is one of the reason we tell patients कि आपने दवाई लेनी है बेशक आप ठीक भी हो गए हैं, आपको सिम्टम्स नहीं है, अगर आपकी इन्फ्लेमेशन है, अंदर सोजिश है, तो this inflammation can cause clots, it can cause stroke, it can फालिज का अटैक हो सकता है, हार्ट अटैक हो सकता है, आपकी वेन्स में ब्लड क्लॉट्स बन सकते हैं. तो these can be life threatening. So that's why it's very important to take care of yourself, take your medications, avoid taking steroids repeatedly. In my practice, अगर किसी को मैंने साल में 2 दफा steroids दिए हैं, इसका मतलब है I need to change my therapy, because steroids on top of that active inflammation, they actually increases your risk of blood clots very high. So blood clot ka risk na sirf inflammation se hai, certain medications also can cause high risk. So there are some new medications. Agar aapne naam suna hoga, tofacitinib, which is a JAK inhibitor, that can also increase your risk of blood clots. So you have to make sure you screen those patients also. अगर मरीज कभी भी IBD का हॉस्पिटल में एडमिट हुआ है, unless the patient is profusely bleeding and now they are developing anemia, hemoglobin 7 से नीचे गिर गया है, so then you may have to pause. Otherwise, all IBD patients who are getting admitted because they are having severe disease or they are in flare, they should get thromboprophylaxis. By low molecular weight heparin ke saath ya Lovenox ke saath, you need to give them thromboprophylaxis for the same reason that they can have blood clots. I have seen personally patients getting strokes. I have seen patients getting pulmonary embolisms. I have seen patients getting deep venous thrombosis, portal vein thrombosis, heart attacks. So it actually is a real thing that can happen in these patients. My last slide before I open, I'm here to answer any of your questions or comments. Okay, what is the implication of this? Why we need to learn about all these extraintestinal manifestations? There is a reason, one other reason, besides being a good clinician, recognizing these complications and manifestations. Sometimes there are pathways which are dependent on certain cytokines. For example, if you have arthritis, you know that arthritis in IBD is typically driven by TNF alpha. So then you can give them anti-TNF medications that will treat both arthritis as well as the joint, the gut inflammation. We also know that a lot of skin problems happen because of interleukin-23 pathways. So now we have a medication called Stelara or ustekinumab, and now there's another medication called risankizumab. So these are your interleukin-23 blockers. So sometimes when we see skin lesions like Pyoderma, gangrenosum, and other psoriasis, we actually then move towards those type of therapies. So even your therapies for IBD can also be guided by the type of extraintestinal manifestations they are having. If the patient is not having any extraintestinal manifestation, no joint pains, no skin problems, no eye problems, they just have, let's say, colitis, no perianal fistulas, nothing is, we call them luminal inflammation. Then you can actually also use a drug called vedolizumab, which is also come with the name of Entyvio, which is a gut-specific, a gut-selective mechanism because it is an anti-integrin. So lymphocyte trafficking to the gut is blocked. So that's how you then only treat with a medication that is working only in the gut and not working systemically. So with that, I'm going to end here. I'm going to stop sharing here, and then I will be available for any questions. So that was my concise, small, quick review of extraintestinal manifestations.
Thank you. Thank you very much, Tauseef. An excellent presentation. I really appreciate आपने टाइम निकाला और मुझे नहीं पता जेट लैग आपको कितना है, but you're looking fresh. Maybe Pakistan effect है आपका. So, but excellent talk. Really, we learned a lot. To open up discussion, Professor Altaf Alam Saab is here. Dr. Altaf, I would like to have your comments.
Thank you, Asad, and thank you, Tauseef, for the passion you have put into your talk. Thoroughly enjoyed. It is really very informative. And it really highlights the importance of IBD as a multi-system disease. One has to be very wary of all these extraintestinal complications when we see a patient with IBD. And you have very strongly emphasized this point, and I really like that, because we here in Pakistan either don't examine at all, or if examine, we have full set of clothes on and we just look at the tummy and that's it. So, it highlights the importance of looking at the oral cavity with a good light, maybe using a tongue depressor and all that, looking at the eyes very carefully, the joints, the skin, and you need to undress the patient as much as possible under the circumstances, particularly in the Pakistani setting, but don't omit. So my advice to all my colleagues is that first take home point here is that you need to be aware of these extraintestinal manifestations in IBD, and please look for them. And to look for them, you have to do a good comprehensive clinical examination, and then you may have to involve other specialities, like Tauseef has very clearly highlighted, and that you may need to have the support of a rheumatologist, an ophthalmologist, and so on and so forth. So don't hesitate to involve other specialities to manage your patient with IBD. So thank you, Tauseef. Thoroughly enjoyed. I'm looking forward to meeting you personally during the PSG. Thank you for coming, and thank you for this wonderful talk.
Yeah, thank you, Ji. Thank you. It was my pleasure.
Tauseef, first of all, to all the participants, we are open to questions. आप अपने question chat में लिख सकते हैं. So we'll ask Dr. Tauseef, or if you have question, raise hand की option है. I don't know कि unmute करके अगर if you want to jump in for with a question, we have time. तो सिर्फ एक चीज मैं आपसे पूछना चाहूंगा, for extraintestinal manifestation, do you like we talked about primary sclerosing cholangitis, autoimmune hepatitis, IgG4 and these things. So आप routinely without any symptom इन टेस्टों को देखेंगे, or say you are alerted by impaired liver function test to proceed further? And similarly, is it a routine practice in United States कि आप उनकी eye examination from an ophthalmologist कराएंगे, और अगर करवाएंगे तो कितनी जिस तरह हम डायबिटीज में देखते हैं कितना frequently कराएंगे? जी please.
Excellent question. इस questions को मैं divide करूंगा दो. एक है कि आप proactively आप क्या कर रहे हैं, and then reactively आप क्या करें in IBD की patient. So the key thing is कि in a dedicated IBD program in United States, most of us use a template. So the patient आता है clinic में, तो we check mark all these things. So एक templated template होता है, and I will be happy to share with anyone in future also. तो वो patients से बाज़ even यहाँ पे तो I'm assuming nurse होगी. America में we have medical assistants. We call them medical assistants or scribes. So they ask all these questions, and sometimes when we go in the room, so हमारा EMR में एक template बना हुआ है जिसमें हमने routinely these questions we have to ask them. We don't just ask them कि आपका diarrhea ठीक हो गया, bleeding ठीक हो गई है, pain abdominal ठीक हो गई है. There is a check mark जो हमने history में पूछना है कि आपको आंखों का मसला तो नहीं है, आपका वजन तो नहीं कम हो रहा, आपको skin की problems तो नहीं हो रही, आपके जोड़ों में दर्द तो नहीं हो रही, आपकी sleep कैसी है. तो इस तरह के, और फिर ओपन एंडेड क्वेश्चन कि कोई और मसला तो नहीं हो रहा जो आप बताना चाहें. तो ये तो हो गया हिस्ट्री में. इट्स वेरी इंपॉर्टेंट, एंड एवरी टाइम व्हेन पेशेंट कम वी आस्क दिस क्वेश्चंस. इट्स नॉट ओनली वन टाइम, एवरी टाइम. अगर आपकी हैवी प्रैक्टिस नहीं है, बाज़ औक़ात गैस्ट्रोएंटरोलॉजिस्ट साल में 3 या 4 आईबीडी मरीज देखते हैं, इवन देन वी टेल देम कि मेक अ हैबिट टू राइट डाउन, even if the patient is doing fine, just write down no EIM, ताकि पता चले कि आपने स्क्रीन किया और हिस्ट्री में लिखा है। और आप तो asking these questions in the history is very important. Second thing, जैसे डॉक्टर अल्ताफ आलम ने भी इस बात को स्ट्रेस किया है कि मेडिकल स्कूल में there is a reason as a medical student we are taught about good physical exam and why हमारे professors हमें कहते थे कि physical exam जो है कितना important है lab test. So this is a classic scenario in IBD जहाँ पे physical exam की बहुत importance है, and documenting कि hair loss तो नहीं हो रहा, आंखों को देखा आंखों में redness तो नहीं है। तो these are screening things that we do all the time and document. जहां labs की बात आती है, तो we don't routinely do labs in United States. Most of the time, patients are already on immunosuppressive therapy. तो जब immunosuppressive therapy में होंगे, and this is one of my talks that I will be giving on Saturday, कि रूटीनली 3 महीने बाद 6 महीने बाद आपने लैब्स करानी ही करानी है। तो आपको उसमें आपने यही देखना है कि लिवर एंजाइम्स तो नहीं बढ़ रहे, एनीमिया तो नहीं हो रहा, B12 तो कम नहीं हो रहा, विटामिन डी तो कम नहीं हो रही, प्लेटलेट्स तो नहीं बढ़ रहे, क्योंकि बाज़ औक़ात इन्फ्लेमेशन की वजह से प्लेटलेट्स भी बढ़ना शुरू हो जाते हैं। अगर आपके प्लेटलेट्स बहुत बढ़ना शुरू हो जाए तो दैट आल्सो इंक्रीजेस रिस्क ऑफ क्लॉट्स एंड थ्रोम्बोसिस। सो यू हैव टू वॉच फॉर दोज थिंग्स। अगर आपका पेशेंट इम्यूनोसप्रेशन पे नहीं है तो मेसालामीन्स पे तो होगा, सल्फासैलाजीन पे तो होगा। एंड रूटीनली द रिकमेंडेशन इज कि साल में 1 या 2 दफा आप उसके रीनल फंक्शंस देख लें, क्योंकि वो इंटरस्टिशियल नेफ्राइटिस इट कैन कॉज दैट। सो अगर आप वो देख रहे हैं तो आप जहां किडनी फंक्शंस करा रहे हैं वहां साल में 1 या 2 दफा लिवर फंक्शंस भी करा लें। आखिरी बात ये कहूंगा कि अगर आपका पेशेंट इम्यूनोसप्रेशन पर है तो the recommendation is you send them once a year to our dermatologist for a full skin exam. जैसे once again डॉक्टर अल्ताफ आलम ने कहा कि there could be cultural barriers कि आप full skin exam नहीं कर सकते। ना सिर्फ cultural barriers, आपके पास time नहीं हो सकता। Even in United States, you have only 15 minutes to see a patient. How can you do a complete exam? वो तो आपका सारा time उसी पे लग जाएगा। तो what we do, we tell them कि once a year you need to go to a dermatologist to have a full exam. और फिर वो dermatologist का तो काम यही होगा, they will do that. So documenting patients who are on long-term steroids, patients who are on anti-TNF therapy, Imuran, we send them to get screened by a dermatologist. Ophthalmologist, rheumatologist के पास हम सिर्फ उस वक्त भेजते हैं जब हमने उनके कोई अलामात हो तब भेजते हैं। स्वाय एक दवाई के जो अभी recently approved हुई है उसका नाम है Zeposia, वो है S1P inhibitor, and I'll talk about it in my talk also on Saturday. तो S1P inhibitor में एक थोड़ा सा रिस्क होता है मैक्युलर एडिमा का। तो जब आप वो दवाई शुरू करते हैं उसका नाम है ओजेनिमॉड, तो उससे पहले आप जो है ऑप्थेमोलॉजिस्ट को दिखा लेते हो कि आंखें सही हैं इसकी, इसको मैक्युलर एडिमा या कोई आई प्रॉब्लम्स तो नहीं है, स्पेशली अगर पेशेंट डायबिटिक भी हो। तो वो एक एक्सेप्शन है। उसके अलावा routinely we don't send them to ophthalmologist or rheumatologist, but we do send them to dermatologist once a year.
जी थैंक यू। ये क्वेश्चन है कि इज एक्जिमा एंड EIM?
I mean, theoretically it can happen. Eczema की स्टोरी जो है ना वो थोड़ी सी कॉम्प्लिकेटेड है IBD में। एक तो ये कि psoriasis तो आपको पता है कि हो जाता है, इट्स एन ऑटोइम्यून। तो सेकेंडली जो psoriasis है ना वो एंटी-TNF थेरेपी से भी हो जाता है। इट्स अ पैराडॉक्सिकल रिएक्शन कि आपने सुना होगा कि जो इन्फ्लिक्सिमैब है या एडालुमिमैब, ह्यूमेरा और रेमिकेड जो है वो psoriasis में भी यूज होते हैं ट्रीट करने के लिए। लेकिन एक पैराडॉक्स IBD में ये है कि जब आप IBD में यूज करते हैं ह्यूमेरा या रेमिकेड, और पाकिस्तान में मैंने सुना रेमसीमा भी मिलती है, तो उससे भी psoriasis हो जाता है। तो psoriasis इज डिफरेंट, और बाज़ औक़ात क्लिनिशियंस को डिफरेंशिएट करने में फर्क पड़ जाता है कि ये एक्जिमा है कि ये psoriasis है। सो दैट्स व्हाई इट्स वेरी क्रिटिकल कि आप उसको डर्मेटोलॉजिस्ट के पास भेजें, अनलेस यू पर्सनली कैन फॉर श्योर डिस्टिंग्विश बिटवीन एक्जिमा और psoriasis. Eczema, typically you can call it an extraintestinal manifestation, but what I have seen कि eczema usually जो है ना वो dry skin और एक allergic phenomena है. It may not be purely an IBD related thing. It could be an isolated thing. IBD के मरीज जो anti-TNF therapy पे होते हैं वो they also have very dry skin. उनकी skin बहुत dry हो जाती है जब वो Remicade लेते हैं या Humira. तो then they scratch a lot. So बाज़ it becomes challenging कि ये क्या हो रहा है, eczema हो रहा है कि ये इनको rash हो रहे हैं या इनको psoriasis हो रहा है. So sometimes that muddy the picture there. So लेकिन eczema itself to tell you कि eczema जो है it may not be categorized by EIM, but अगर किसी को eczema है तो then you need to treat that.
Thank you. Any other question from the audience?
एक और टिप दे देता हूं जाने से पहले. बाज़-औक़ात आप IBD के मरीज आते हैं आपके पास और आप उसको दवाई शुरू करते हैं, मसलन आपने उनको इम्यूरैन दे दी या एज़ाथाइरिन दी या आपने बायोलॉजिक थेरेपी स्टार्ट कर दी सच एज रेमसीमा या ह्यूमेरा या रेमिकेड जो भी अवेलेबल है. तो मरीज आता है आपके पास दोबारा, कहता है कि मेरे तो बाल गिरना शुरू हो गए. तो वो कहता है कि आपने क्या दवाई दे दी है, मेरे तो बाल गिरना शुरू हो गए. तो दिस इज अ फिनोमेना कॉल्ड टेलुजियम एफ्लुएम. तो उसमें ये होता है कि बाल जो आपके पुराने बाल होते हैं वो गिर रहे होते हैं और नए बाल आ रहे होते हैं. तो वो स्टेज जो हेयर लॉस की, अगर आपको इफ यू रिकॉल कि हेयर लॉस की जो होती है ग्रोथ की, वो एक स्टेजेस होती हैं. एक में बाल गिरते हैं फिर नए आते हैं. तो जब आप ये दवाई शुरू करते हैं तो वो सारे पुराने बाल गिर जाते हैं और नए आते हैं. तो न्यू हेयर कम एंड ओल्ड फ्रेजाइल हेयर फॉल ऑफ. लेकिन वो स्टेज ऐसी होती है कि सारे गिर जाते हैं या बहुत सारे गिर जाते हैं. तो मरीज परेशान हो जाता है कि मेरे बाल क्यों गिर रहे हैं. तो अक्सर मैं मरीजों को बताता हूं जाने से पहले कि मैं आपको ये दवाई दे रहा हूं और हो सकता है आपके बाल गिरना शुरू हो जाए. एंड दैट इज अ गुड साइन बिकॉज नाउ यू गोना गेट गुड हेयर आफ्टर दैट. सो डोंट वरी इफ यू स्टार्ट गेटिंग हेयर लॉस. बाज़ बात फिर मरीज दवाई छोड़ देते हैं और आई अज्यूम पाकिस्तान में भी यही होगा जो अमेरिका में होता है कि फिर मरीज आता ही नहीं है कि डॉक्टर ने मुझे ऐसी दवाई दे दी कि उससे मेरे हेयर लॉस हो गया. आई एम नॉट गोना गो टू डॉक्टर अली एनीमोर बिकॉज ही गेव मी अ मेडिकेशन दैट कॉज माय हेयर लॉस. स्पेशली विमेन में ये प्रॉब्लम होता है. तो देन यू हैव टू एजुकेट देम कि अगर ये है, दिस इज अ वेरी वेल नोन फिनोमेना, telugium effluvium, and your hair will come back, and actually better hair will come back.
Thank you. Another question, can patient present with more than 2 to 3 EIM at time, and does it affect the course of the disease?
बहुत अच्छा क्वेश्चन है. In the beginning I actually talked about it कि at a time 5 भी हो सकती है एक्स्ट्रा इंटेस्टिनल मैनिफेस्टेशन, और कुछ ऐसी होती हैं जिनमें कॉन्कमिटेंट होती है. मसलन एरिथीमा नोडोसम में आर्थराइटिस भी होता है, यूवीआइटिस में भी आर्थराइटिस होता है. तो यू हैव टू स्क्रीन एंड मेक श्योर कि अगर आपको एक एक्स्ट्रा इंटेस्टिनल मैनिफेस्टेशन मिल गई आर्थराइटिस की, आपके अच्छा जी मुझे आर्थराइटिस मिल गया, एंड यू फॉरगेट अबाउट स्किन लीजन. सो मेक श्योर यू डू गुड एग्जाम, मेक श्योर यू लुक एट द ओरल म्यूकोसा, आईज, स्किन, जॉइंट्स. तो एक से ज्यादा हो सकती हैं. तो सेकंड है, does it affect the course of disease? Some extraintestinal manifestations parallel the disease course, some runs independent. Episcleritis, scleritis parallels the disease activity. आप उनकी Crohn's colitis को ट्रीट करेंगे, उनका स्क्लेराइटिस एपिस्क्लेराइटिस ठीक हो जाएगा. एरिथेमा नोडोसम हुआ है, आप उनके Crohn's and colitis को ट्रीट करेंगे, एरिथेमा नोडोसम भी ठीक हो जाएगा. कुछ इंडिपेंडेंट रन करती हैं. फॉर एग्जांपल एक्सियल आर्थराइटिस जो है आपका, मेन बैक का आर्थराइटिस हो गया आपका, या आपका मोर देन 5 पेरिफेरल जॉइंट्स का आर्थराइटिस हो गया, या आपको यूवीआइटिस हो गया, तो या पायोडर्मा गैंग्रीनोसम हो गया, तो और पीएससी हो गया. तो दीज दे रन इंडिपेंडेंट कोर्स. दे हैव, आप उनकी डिजीज ट्रीट भी कर लेंगे, वो रिमिशन में भी होंगे, they will still can get these extraintestinal manifestations. And that is another reason you ask your patient to come back and see you even if they're doing well, because they can develop these extraintestinal manifestations and you have to keep watching for that. So हर 3 महीने बाद, 6 महीने बाद आप उनको बुलाकर क्विक एग्जाम कर लें, देख लें कि make sure, or make sure you educate them बाज़-औक़ात आपकी logistically it's impossible to keep bringing these patients. They may not want to come. And I'm sure पाकिस्तान में भी ये मसला है. अमेरिका में लोग कहते हैं कि भाई हम क्यों बार-बार पैसे दें आपको. तो कोपे इतनी ज़्यादा हो गई है, deductibles कम हो गए हैं. तो so what we tell them, we educate them कि भाई just make sure कि आपको arthritis, uveitis, skin problems तो नहीं है. और अगर हो तो please call us, please make an appointment and come back as soon as possible.
जी, थैंक यू. एक आखिरी क्वेश्चन मेरी तरफ से, एंड देन वी कैन सी. तौसीफ, आपने बड़ा अच्छा बताया एक्स्ट्रा इंटेस्टिनल मैनिफेस्टेशंस के ऊपर. ऑफ कोर्स कुछ तो बड़ी क्रिपलिंग, डिबिलिटेटिंग हैं जो मैनिफेस्टेशन है. इन सब में कोई ऐसी है जिसका प्रोग्नोस्टिकली सिग्निफिकेंस बहुत ज्यादा हो इन टर्म्स ऑफ सिवियरिटी ऑफ आईबीडी, कि अगर ये डेवलप हुई है तो उसको आपका क्या एक्सपीरियंस है?
आपका सवाल मुझे बिल्कुल थोड़ा सा समझ आया है, तो लेट मी आंसर एंड सी इफ आई आंसर योर क्वेश्चंस. अगर नहीं तो आप मुझसे दोबारा पूछ लेना. कि प्रोग्नोस्टिकली कुछ हैं जो बहुत डेंजरस हैं, जैसे कि यूवीआइटिस, प्राइमरी स्क्लेरोसिंग कोलोंजाइटिस और डीवीटी. ये तीन तो prognostically are very dangerous, क्योंकि you don't want to, you can lose your vision, permanent disability. Primary sclerosing cholangitis में you can get cholangiocarcinoma, or DVT में you can get blood clot, and that you can have pulmonary embolism or stroke. तो अगर disease severe है तो उस severity की वजह से कुछ extraintestinal manifestations हो रही हैं. तो उसमें as such कोई category नहीं है कि अगर आपकी बहुत disease severe है तो ये वाली. I think because if you recall in the beginning I told you कि there are two buckets के extraintestinal manifestations क्यों होती हैं, और बहुत सारी theories हैं कि क्यों हो रही हैं extraintestinal manifestations. So it's very hard to tell कि अगर बहुत ज़्यादा disease severe है तो कौन सी extraintestinal manifestations जो है वो prognostically severe होगी. ये हमें पता है कि अगर आपकी disease severe है तो most common जो है वो arthritis होती है. लेकिन हमें ये नहीं पता कि इनमें से prognostically कौन सी dangerous है जिस पे आपने फिर you have to keep an eye. लेकिन कुछ हैं जो हमें for sure पता है कि uveitis, PSC and blood clots, these are dangerous. Obviously skin cancer is dangerous also, लेकिन skin cancer ये है कि मरीज को भी पता चल जाएगा कि उसकी स्किन पे कुछ हुआ है, तो it can get detected earlier. uveitis में ये है कि पेशेंट्स इग्नोर, और बाज़ औक़ात वो डॉक्टर्स के पास जाते हैं, इवन इन यूनाइटेड स्टेट्स, वो कहते हैं हमारी आंखों में मसला आ रहा है, वो कहते हैं तुम्हारी आंखों की नजर कमजोर हो गई है. तो they actually don't go to ophthalmologist, they go to optometrist. तो वो अपनी आंखों की नजर ही ठीक कराते रहते हैं अनलेस वो फिर जब तक डेंजरस यूवेइटिस डेंजरस लेवल तक ना पहुंच जाए. और इसी तरह पीएससी का भी नहीं पता चलता, वजन कम हो रहा है, वो अब बाज़-औक़ात क्रोन्स डिजीज में भी वजन कम होगा, कोलाइटिस में भी वजन कम हो रहा है, लिवर एंजाइम्स अगर आपने चेक कराए वो फैटी लिवर में भी होगा, मैलन्यूट्रिशन में फैटी लिवर होता है उससे भी. तो यू जस्ट हैव टू हैव वेरी, इफ यू डोंट नो यू विल मिस इट. तो वो आंख ओझल पहाड़ ओझल. So you have to know these things, and once you know these things, then you think about these things also. कि अच्छा PSC तो नहीं हो रहा, तो let me at least do a quick imaging ताकि मैं PSC rule out कर सकूं.
Thank you very much indeed. I got my answer by the way, so thank you very much. I think I will go to Professor Altaf for some concluding remarks, and then over to you, Kiran.
Thank you, Asad, and thank you, Tauseef, once again. We have learned a lot, very good attendance, more than 50 people around, and we learned a lot from your talk. So very pertinent and very informative. So thank you very much, and please continue to contribute for our ECHO project and for IBD SIA project that we are running on PARSA ECHO Pakistan. Thank you very much. Over to Kiran, please.
Thank you very much. As you know कि ये series designed है कि once a month session होता है, और we are trying to plan interesting topics for you on monthly basis. So keep joining us and be part of the IBD series in future as well. We are grateful and thankful to all the participants and you who have joined us along with our expert in SIA. Genix Pharma for the unrestricted educational grant, and our course director, Professor Tauseef Ali Sahab, and team at PARSA ECHO Pakistan. Allah Hafiz. Uzair, you can please call off the meeting.
Sure, ma'am. Allah Hafiz, everybody.